Okay, let's get started. Good morning, everyone. It's a great honor to welcome Dr. William Choi Donahoo to speak at our center today. Choi and I have a very long-standing professional relationship and have collaborated on several federal funded projects over the years. So I'm very pleased to host him for this event and provide his introductory remarks today. Dr. Donahoo is a clinical professor and the chief of the Division of Endocrinology, Diabetes, and Metabolism at the University of Florida. Since 2010, his research has focused on leveraging electronic health records to address critical epidemiological and pragmatic outcomes in diabetes and obesity. His work includes the development and validation of algorithms to identify type 1 and type 2 diabetes, as well as metabolic dysfunction associated steatohepatitis, MASH, and advanced fibrosis. He has also investigated the risk of increased opioids use following bariatric surgery, off-target effects of new glucose-lowering drugs, medication adherence among American Indians with type 2 diabetes, and disparities in telehealth utilization and diabetes diagnosis following COVID-19. We're very fortunate today to have him with us, and we're looking forward to an engaging and insightful presentation. Troy, you have the floor.
Thank you very much, Wei, and thank you all for joining. Actually, I'll have a slide that specifically says this, but none of this work is really my own. It includes several there, and I see Rosette's on as well. So this is really your work that I've been lucky enough to be part of. But let's go through, and this is in many ways also kind of more of an introduction or primer to the real world data, and or you could take it as my history growing up with clinical research networks. So with that, as far as disclosures, I've had funding from PCORI and PCORNet, SPAN and Supreme DM that I'll talk a little bit about. One Florida Plus, which is my main site now. The NIH, Rosette and I had the diabetes and obesity disparities with COVID, medication utilization, CDC with Mini Sentinel and Dakaya HRQ, and then internal funding from a lot of sources when I was at Kaiser in Colorado, the College of Pharmacy, and Hobie here at UF, as well as Endocrine and Hobie with some of the stuff that I'm not going to talk about. So this is probably about 6 months old, but when I first put this talk together, I kind of went through and saw, okay, since I started in this area, what studies have I done that I've been part of that have been published? And there's probably now 5 or 6 more that could be added. But just to see kind of what I had done, where they were funded, and the different databases that were used, as well as the research tools that were being used in the disease states. So with that, just to review, the ones in red, are the ones that I'm going to talk about specifically here. The one in blue on currently internal, but we're looking at external funding as well, is a lot of work I've done with Serena Gu here, looking at cognitive dysfunction, Alzheimer's disease, and Alzheimer's related dementia, and diabetes, glucose lowering drugs, and delaying that. That's a whole nother talk, and kind of a really interesting area to go on. And I've also mentioned some of the obesity work that I've done with One Florida and with the NIH and others that I'm not going to talk about either. So that leaves it to just these few studies highlighted. So let me give you my true disclosures, my scientific disclosures, so you know where I'm coming from. So first is I don't have any formal training in medical informatics or epidemiology. I've taken a lot of epidemiology classes through the CTSI, but nothing formal, no certificates or anything. And I'm certainly not a statistician, although I could do some basic statistics. I'm not a programmer. I'm so old, though, that my first computer was a Commodore 64, and I learned how to program that in BASIC. I just then went on the medical pathway and never went back to programming. But the real key to this is I truly have had the great fortune to have been a content expert and working with some groundbreaking researchers, again, including many on this seminar today, in this field since way back in 2011. So I thought today we'd go through kind of the specific methods used in real-world data epidemiology research, specifically around diabetes, and get an idea of our basic understanding of the prevalence and incidence of diabetes and how we've evolved to being where we're at now. And then give a couple of quick examples, if there's time, of where we've used real world data and to evaluate glucose lowering medications, medication adherence, as well as some outcome data. So let's talk about the first one. And I'm going to go way back to probably almost 20 years ago. So as some of you may know, I came from the University of Colorado and did all as a fellow and junior faculty there. My research was focused on obesity and diabetes, but using the small clinical research center studies mainly on lifestyle interventions. I moved to the University of Vermont for a couple of years where I was able to continue that. And towards the end at the University of Vermont, get an R21 to evaluate the effect of intermittent fasting on people with obesity. And it was the first true alternate day fasting study in obesity that was ever completed. It was actually completed. I moved back to Colorado and I moved to Kaiser Permanente. And for a variety of reasons, Kaiser Permanente isn't a small clinical research center type organization. And so with much struggling and doing a lot on my own, but with primarily great co-investigators, that study was on intermittent fasting was completed. And I'm actually really proud to say that Vicky Catenacci, who was a junior faculty at the time, helped me complete that study, took those data, got an R01, and that study on alternate day fasting or intermittent fasting was just published 2 weeks ago in Annals of Internal Medicine. So my basic research or my clinical research, patient-oriented, has continued, but kind of without me. Since I really wanted to stay in the research realm, even though Kaiser was more of a clinical care organization, I was pretty fortunate that a couple of things happened and came together. One was this was a time when Obama was elected, and so PCORI was started. And there was a guy from PCORI named Joe, or from Kaiser, California, named Joe Selby, who was a primary care provider and a researcher, who was tapped to be the chair, the head of PCORI. He had a lot of ideas of how PCORI should go and grants that should be started with it. But obviously, when he was now the lead, he couldn't continue with those grants. And so I was very fortunate in that John Steiner, the senior author on this paper, had been one of my both colleagues and educators when I was a medical resident, even a medical student and fellow. And so he had moved to Kaiser to do research. And so I was working with John, trying to find other things to do in the research field. And he invited me to be part of these studies of the Supreme DM and also the SPAN study, which focused more on obesity and other things. So I was indirectly, I was kind of more of a content expert, but I have seen this grow since the beginning of its starting. So let's go through kind of this study specifically in a little bit of detail, but also kind of use this as an example or as a tool to learn about kind of how this work has been done. So from their introduction, diabetes prevalence and incidence had been increasing for several decades, and studies from Denmark and the United Kingdom, which have robust databases, suggest that diabetes, however, recent studies from Denmark and the United Kingdom suggested that that there had actually been a little bit decline over the last few years. And so this was also at the time when the ADA switched from just using fasting glucose or an oral glucose tolerance test to being able to use the A1C for testing. And so they asked the question, their aim was to fill that knowledge gap of both, did the A1C testing for diabetes affect either the number of people being tested or diabetes incidence? And so this was kind of the first population type study. I'll talk about the others to look at this. So this was the Supreme DM, or Surveillance, Prevention, and Management of Diabetes mellitus, multi-center consortium of member organizations of what was the HMO Research Network. It collected data they had been collecting data on approximately 16 million individuals of all ages, 10 US states from 2005 to 2011 for this study. And research institutions have developed a distributed virtual data warehouse, contains information on demographics, prescriptions, lab values, and all this stuff. And so, so this was the first true clinical research network in the US. Granted, there have been others, and there are still very robust others in Europe and all, but this was the US-based one, given our randomness of insurance and things like that. This is also people, especially at that time, who were Kaiser members, is what their patients are called, are very, oftentimes very wedded to Kaiser. They'll be a Kaiser member from birth to death. So they have pretty good longitudinal data, better than most other places. And the Kaiser physicians, really all they do, they get paid one price, one salary. So all they do is work on the clinical piece. Everybody has a primary care provider, so they don't have to worry about upcoding for better reimbursement or any of these other things. They're paid a salary, and so they can just do their clinical work and move on and not worry about upcoding. So before this clinical research network, what it was like doing real-world data research, as some of us may remember, it was all centered around the electronic health record. And with the electronic health record, or not the electronic health record, I'm sorry, the paper record review. So you'd have an idea, you'd maybe, while you were on the wards, jot down a few names of patients that had, two diseases combined with each other. Oh, it seems like a lot of people with cystic fibrosis are getting diabetes now that they're getting a little bit older. And then you go back and pull all the charts that you've seen of patients with cystic fibrosis, look and see if they have diabetes. But it took a lot of work. You'd have to, try to pull different things together. And if you're lucky, they might have been in a clinical trial or something that you can get more data from that. But this was a very time-consuming, labor-intensive activity to do the hand record review. So then as the EHR came about, and as different organizations incorporated the EHR, which Kaiser did very early on. They were using Epic over 20 years ago. We were able to then pull together the admin data, including the diagnosis and all, with the pharmacy data and the laboratory data and the radiology data and then the clinical notes data to either, for us in the clinic, look at the far right panel going back of cells. So you can see your patient and look at their diagnoses and medications and blood work, or across the blood panel, for example, to look at the A1Cs over time in our population of patients, or to do research looking at, for example, those with diabetes and what medications they've been on over time and how that relates to A1C. And I'll show an example of that. So this pulled together administrative data, hospital activity reimbursements, ICD codes, claims data, ancillary data, including pharmacy lab, radiology, pathology, and unstructured data in the clinical text. And I know a few years ago, a lot of my data scientist colleagues were like, oh, there's so much data in the clinical text. And I was like, slow down. You haven't actually looked at these notes. Those of us who work day to day know how truly bad the clinical data is. It's all cut and pasted with very little new information in it that you really have to dig through. But there is some important information in the clinical text if you can get through all the bad data on top of it. So this is then kind of where it builds upon, and I know this is pretty basic for a lot of you guys, but kind of one of the places it started outside of the HMO Research Network was this I2B2, which used the kind of same format of the research network to develop a set of topics or things that you could then transform it into a table and send it to a single site that could develop it beyond that. So just real briefly, and again, this is really basic and there's much better places to learn more about it if you really want to. There's a common data model, the PCORI or the PCORNet, which I'll talk about in a second, developed that then has different categories and then can go through the schema to actually link things in a meaningful way for you at a given time. So I'm going to take a slight step aside next to talk about possible, where you can get the data source. When I started with this 15 years ago, it was the HMO Research Network was really the only thing in the US, anything like that. There were some registries, some more robust than others, but everybody had to develop their own registry and it was hard to talk to each other. And now you'll find that there's a whole bunch of different data sources to choose from. And many of you on the call probably have more experience with others than I do. So this is an older slide, but it shows you kind of how much using the I2B2 you can get out of it. And so again, an older slide, but here at UF Health, between our Gainesville and Jacksonville campuses, over almost 2 million patients and, over a billion and a half facts. If you go through one Florida, and this is again, old slide, 15 million, 17 billion. And then there's a national level of I2B2 that you can get to. But obviously, the farther up you go, you get more patients, but you get far less data and not as clean data. And so with our I2B2 or our integrated data repository, we can pull out not just the aggregate data, but with the appropriate IRB approvals and all, we can actually get the patient's charts to then go through them and try to make connections with that. That One Florida I mentioned is now One Florida Plus. You can see, and you guys at Emory are part of it, as are the University of Alabama, Birmingham, University of Arkansas, UC Irvine, and the University of Minnesota are network partners as part of the, and you can see the others, Tampa General, Miami, are part of our One Florida network with 26 million patients, 10,000 healthcare providers, and 1,000 practices, 72 hospitals that we can all pull together to get data. And then beyond that, we're one of the clinical research networks, but there are 7 others that all collaborate and all basically talk the same language to pull the data together. This is just an example from the CoreNet site, a clip of the Advanced Greater Plains Insight, which is largely New York. And then us in One Florida, that includes you guys in here, and us and others. The PATH network, largely in the Northeast, in addition to the other one, PedsNet, which is just pediatrics, and then ReachNet, which includes some of our other southeastern sites like Ochsner and Tulane, as well as UCSF, and then STAR, which Rosette actually worked at for many years with Russell Rothman, and also includes Duke and UNC and others. So between these, we can really pull together a large number of patients demographically distributed to determine some of these questions with it. So one of the kind of not rules, but one of the things that we try to do at the University of Florida Endocrine Division, the faculty think about trying to incorporate AI into all of their talks in at least one little way or another. And so as I was doing this talk originally a few months ago, I asked Microsoft Copilot to compare the benefits of real-world data, including CoreNet, MarketScan, the Medicare Administrative Database, and Indian Health Services, which are the ones that I had been on papers with those that colleagues had used. Copilot sent back, here's a comparison, and pCoreNet has these benefits. And so it went through these, and I said, okay, what else should we include with it? And it didn't include Epic Cosmos, so I asked specifically about that. And then many of you probably know much more about this than I do, but I'm always fascinated by, I could do that in, about 3 minutes, and then ask it to summarize the information in the table, does that in about a minute, and then convert the table to a PowerPoint slide, and it does that in another minute or two that you can download. And so with that, and a little tiny bit of formatting changes, here's what Copilot told me about the different data sets. And I really kind of like this slide because I think it helps to go this slide and the next one to go through the different ones. So the CoreNet's large, standardized data, patient-centered, but variable quality, and limited longitudinal data. MarketScan, comprehensive and a large sample size, but lacks clinical data, potential bias because it's only people in MarketScan who have certain insurances. And it also costs to be part of it. Medicare, you can read extensive coverage, but limited to Medicare population, and it's more administrative. You can't get some lab data or other things from it. Indian Health Service, focused on the Native Americans, integrated, but very limited geographic coverage, and does have some data issues. But it is a comprehensive care data and an integrated system where everything is covered for the for those in the system. Sentinel is part of the FDA collaboration. As we were talking about a minute or two ago, we don't know where FDA is going to be with this, but this is where we have now large diverse population, comprehensive data, but it's really for safety surveillance, and it's really hard to get data through this from the Sentinel system. And then a few others that came up: Optimum Labs, cost and data complexity, NHANES, self-reported limited data, and I hope, but I'm not 100% sure that it's still publicly available. Watson, very large database, but access restrictions and all. And then Epic Cosmos, that I know some of you are using, but I don't, and we're not as much here. So this is Epic Cosmos. It integrates all the Epic systems into one clinical research network, so to speak. You can see millions of patients, billions of encounters, billions of face-to-face visits, thousands, hundreds of thousands of physicians and hospitals and beds. Here are all the sites that are part of it, including, I highlighted this, all these sites, including us in Florida, Emory, but Arkansas wasn't part of it, and you guys at Grady aren't part of it. And so it's a pretty big network, but some limitations with it. And so let's kind of move on and talk about kind of the methods. And going back to this original paper. So for each year, they identified all the members participating in health systems who are 20 or older and at least 18 months of enrollment prior to January 1st. So these were people who they knew had been in the system. There was a good chance that they had captured in the past 18 months if they had diabetes or not, and they could still have a large population. Many of our databases, people come in and out, so we don't have 18 months before, or we don't have all the data from every visit they had in 18 months before. People were not enrolled who weren't enrolled for the full year were excluded from both the numerator and denominator. I highlighted that because in this type of research, this is a key part. And they were also excluded from numerator and denominator if they met criteria for diabetes in prior years. So then how did they determine what diabetes was? And this was, in essence, the first computable phenotype for diabetes. And this is something that I think we're getting better and better, but I don't know that we still have the perfect computable phenotype for diabetes, especially separating type 1 and type 2 and others, although I'll show you what I think is pretty close to the best. So they used diagnosis, either one inpatient diagnosis, because they thought that had to be very good for billing reasons, or two of a high A1C, fasting glucose over 126, random plasma glucose over 200, an outpatient diagnosis for diabetes, and any anti-hyperglycemic medications. Remember, this was well before GLP-1s and SGLT2s and others, but they still had some crossover with metformin and thiazolidinedione. So they had rules against using those. So they developed this computable phenotype, which is definition of a condition, disease, or characteristic based solely on data from the computer. And it helps define a specific population with conditions of interest, can be combined with other criteria, age, yada, yada, for a variety of purposes. So for those of you who aren't data scientists or in this area, but are more basic scientists, think about a computable phenotype as your antibody to find the protein that you want to find as the disease or something like that. And like all the antibodies, they have different sensitivities and specificities and may work in one assay or another assay. And so they have to be very clearly defined and tested as well. So a computable phenotype is used by quality organizations, and it doesn't necessarily have to be perfectly sensitive and specific when used in a huge population of patients for certain quality measures. In research, we wanted a lot better. So comparative effectiveness studies or interventional trials, we want to be sure we're getting the right patients with it, especially if we're not meeting them to know that they're right. And also for drug safety and surveillance, and healthcare, personalized medicine, quality measurements, and in our research as well. So I love this slide because I think it shows kind of the differences and the complexity of computable phenotypes. And when I started, the first disease I worked with was obesity. And obesity is extremely simple. So down here, way in the bottom corner. So the data are very structured. There's a height and a weight. If you don't look at the new Lancet recommendations for diabetes, that is, or for obesity, it's BMI. So there's a height and a weight, very structured, easy to find. And again, not looking at the new Lancet suggestions for obesity, we have very clear BMI criteria. So easy to do and easy to do research on obesity, prevalence, and all those types of things. Diabetes is a little bit more difficult. We saw that, it's medications and A1C or fasting glucose, and then we have pretty specific glucose-based criteria of an A1C over 6.5 or fasting over 126. So diabetes in general is pretty easy. Now, when you want to start to separate out type 1 versus type 2 diabetes versus other, it gets more complex because, and I'll show you some of the reasons why. And then I have done a little bit using more kind of machine learning type stuff in metabolically associated steatohepatitis, and many others have gone on beyond the little that we did. But that's more complicated because people can't really all agree on diagnostic criteria. And a lot of it is based on biopsy or other non-structured data that's not in the EHR. And although things are coming along quite well in this area, it's still a pretty difficult place. And even pathologists looking at biopsies will argue with what stage it is and things like that. So this kind of gives you an idea that things like obesity are easy. Type 1 versus type 2 diabetes, not so much. So remembering a computable phenotype is only a tool, like an antibody to identify your protein, and add inclusion and exclusion criteria. But like an antibody, it has to be validated in your system. And I'll show you why in a second. And unlike other things, when we're doing true clinical research with a drug study or something like that, the data sources aren't all one database. The care isn't, you're not coming in at 3 months, 6 months, 9 months to get your labs done. Timing is off. You might miss an appointment or two. And the data quality is highly, highly variable. And so I love this quote by Rob Califf, our former FDA head, that this is not push button research. Methods, expertise, and sleeves rolled up data curation is required. And I think sometimes people forget that and just say, oh, we'll use CPT codes, or we'll use this or that, and it'll be good enough. And it might be good enough, but it also might be getting us to the wrong answer. So making sure that you're really doing the hard work behind curating the data and making sure you're getting the right answer with it. So let's go on to how they did this. And I know time is running out. So they did incident diabetes and compared who developed diabetes to those who didn't. And again, being sure that you have the know the numerator and denominator with this. And basically what they found was that there was about a 10% new incidence of diabetes per year in the Supreme DM database. And that there wasn't any increase between 2006 and 2010. Maybe a small increase in 2011 with a shift from fasting to A1C, and significant only among racial and ethnic minority groups. And so with that, that's how the first of the real world data sets came to be to find the incidence of diabetes. Around that time, there were also a lot of other surveys. The National Health Survey was a representative sample, have the best epidemiological data possible. But how they determined diabetes and diabetes type was just asking the patient if a doctor told them what age they were diagnosed, if they used insulin, and if they had type 1 or type 2 diabetes. And I don't know about your populations, but a lot of mine don't know the difference. Sad to say, some of even the physicians don't know the difference and think type 1 just means you're on insulin. The NHANES survey that I mentioned used age of diagnosis, age of insulin initiation, and current use of insulin as the differentiation between type 1 and type 2, which includes others. The type 1D exchange, this doesn't show their data, but is a set of specialty clinics throughout the nation who look at academic medical centers who treat people with type 1 diabetes and have pretty good data on things like A1C by age and things like that. And they've tried to use their population to estimate incidence and prevalence of type 1 diabetes, but it's not a very good sample of the population. It's a very select group. And then the best and biggest one that's been done is the Search for Diabetes in Youth, which was led by some colleagues that back when they started it, I was still in Colorado, Dick Hammond and Dana DeBalia, as well as others, and then Jean Lawrence, who I worked with on Supreme and on the SPAN studies. And so how they did it, was specifically in youth, initiated in 2000 at 5 sites and a diverse population, active registry, and annual incidence, race, sex. And they used surveillance of the different sites, including endocrinologists, other healthcare providers, hospitals. You can read through that, and a high degree of ascertainment for both type 1 and type 2 diabetes. But this is how they did it, of all the visits and work that it took to get this good of a prevalence and incidence of diabetes in this younger population. So you can see that they did a great job, but with their prevalence, but it was at the expense of a lot of time and work and couldn't be really generalized to the population. So based on the Supreme study, we initially did some work with the Mini Sentinel database to validate what we had done in Supreme DM, which only worked partially in Mini Sentinel. So we took that data and used another algorithm, the Clompus algorithm, to try to separate out type 1 versus type 2, specifically in adults. And with that, you can see the different criteria of glucose-lowering medication, or urine test strips, labs, urine, and the different ones. and then kind of put it all together, did chart reviews, and came up with, and this was part of the chart reviews, just to show you, this was Kaiser, Colorado, even in the Kaiser, Colorado system, very relatively few people, even with type 1 diabetes, less than 30%, had either antibodies or a negative C-peptide, so didn't have the testing that made us comfortable. And the testing goes all the way back, so it's not that it fell out of the chart, that made us feel comfortable using that they had type 1 diabetes. Nonetheless, we had a 95, 96 positive predictive value to show a prevalence of about 4.5 to 5% for type 1 diabetes. So then Jean Lawrence took kind of her just CPT or not ICD codes and showed that she got that same sensitivity and specificity in the youth onset type 1 and type 2 diabetes in the Kaiser, California database. And so this was about when I came here, and I tried to do the similar type of thing here, starting with CPT codes, me and a bunch of others that you could see on there. And our first pull of the data, just using CPT codes, we had pretty good positive predictive values and negative predictive values. But this is where data curation and roll up your sleeve stuff really helps, in that we had, 20% of the population with type 2 diabetes who were 0 to 5 years of age, which I don't think I have ever seen. But I think so many primary care providers out there are just so used to coding for type 2 diabetes that anybody who comes in their office with diabetes, it's coded as type 2 diabetes. We went through several iterations to get a better value with this, but you can see in our initial one Florida database, we still didn't do perfectly well, because only 92% of the kids and young adults with type 1 diabetes, we're pretty sure is type 1 diabetes, came up being on insulin, and we're pretty sure 100% of them should be. So, so this was just mainly to show that it isn't roll up your sleeve science. You have to, or push button science. You have to really roll up your sleeves and go beyond there. So, going on from here in the next couple of minutes, and I know I'm right at time, Rosette was able to take on an initial thing using all these data on computable phenotypes with a PCORNet site, and her and Russell invited us in One Florida and a couple of my former fellows to be part of it. And so with this, we were able to develop a computable phenotype in the PCORNet Clinical Research Network that did pretty good with 96.2 positive predictive value based on record reviews. And so it's an innovative data source for future research studies. And then the CDC decided, the search study was great, but we really need something to look at throughout the country that could be done quickly. And so, and we and Zhang and a bunch of others from UF at the time and One Florida were part of the Dakaya study that I'm not going to go into in much detail, other than to show you that rather than just a couple of things, computable phenotype, we developed with a lot of work and a lot of repetition and all, a decision-based tree to determine type 1 versus type 2 diabetes that looked through kind of categorization rule and then a checklist with it. I just want to cut to the chase of With this 93% sensitivity and specificity versus a rule-based algorithm that's about the same, and the search algorithm that's about the same. But as far as for sensitivity, specificity, it does a little bit better, but positive predictive value, it does good. The challenge in type 2 diabetes in children and adolescents is because it's so rare and there's so much type 1, the positive predictive value is going to be a little bit less. But especially compared to the search, which is thought to be the standard of care, it did much, much better than that, and about the same as the rule-based. But specifically, when you look at different examples of it, compared to search, especially in the Hispanic population, there's a big difference. And this just shows it through the state. I'm going to just really briefly mention because it was because of Emory, people like Jithan and Mohammed, Mo and Rosette, that we did this study looking at the incidence of new onset diabetes. And I don't know if they've talked to you about this, if any of them. I've missed it if they have, but Jithan did an amazing amount of work and did show that, interestingly, that like others and about at the same amount as others, those at the time of COVID who were exposed had significantly more new cases of diabetes relative to the unexposed, which is the center line. And actually the historical controls had less, so that suggesting the diabetes incidence has increased, but less so than the unexposed controls. So I think I'm going to just not show you the examples and go on to questions for the last 10 minutes. But happy to go from there, and thank you. And for those of you not from Florida, this is a little holding pond between the parking garage that I used to park at and where my office and clinics are. And you can see the Gator, just to acknowledge that the Gators were national basketball champions this year, and Egret there, who's thinking, please don't come and eat me. So thank you.
Thank you, Troy. This is very wonderful. And also, yeah, my office is, I have to go through the same path from the parking lot to my office. So I recognize this pond, I recognize this gator. So it's hilarious to see this picture. And yeah, so I think this is a good time for the folks on the call to ask questions. You can just directly unmute yourself to ask, or you can just put it in the chat.
And again, if I didn't say it before, thank you again that I see on Rosette, and I'm seeing anybody else that was part of this, but you and Jithan carried our studies, so thank you, and looking forward to us maybe working together again soon.
I was going to say, it's so nice to see you, Troy. I feel like we were meeting very regularly for a while, and then to kind of get that work done. I did have a question also, and yes, I think a huge help to me when I first came here was recognizing that even though I had worked on STAR CRN before I came to Emory, coming to Emory, which is still part of PCORnet, but a different CRN, there's some investment of time in learning the different CRNs, and kind of each of them has their own method that's important to know when you're, like you said, it's not just a push button approach. You have to really understand where the data is coming from. Along those lines, I wonder if you have any comments on, I think a lot of us have done work where we're looking at retrospective data because these big data sources have been so powerful for that. But now I think there's also a lot of interest in seeing how we can use these to design smart prospective studies where we can really minimize some of the burden that we're noticing on like, doing a pure clinical trial outside of all clinical settings. Maybe we use this to an advantage. I know for me, it's always something interesting, but I don't know if we've done a ton of those projects just yet. And it sounds like the future work you guys are looking at right now with, for example, the dementia project. Those all sound like ones where you're doing that. So could you give us some thoughts on how that works?
Sure. So I think great question, and I agree. I think my big learning coming from Kaiser and was their HMO research network and developed it. And everything was so refined because it was developed as the first one to then One Florida, which was less than a year old, was a huge learning. And so I think each network and then knowing a little bit about the others is definitely helpful, but learning that piece. I think you're right. I'm not positive if I were to look in the future, how much our PCORnet research networks, how strong they're going to be as just data-only research networks because of things like Cosmos and others. Whereas I think where they will be really strong is prospective type studies. So the study you mentioned, and we're still in the process, we've got an initial approval from PCORI to write a full grant with it, is in using retrospective data, some from One Florida, some from our IDR, some from Medicare. It looks like people with diabetes who also have Alzheimer's disease or related dementia and who use a continuous glucose monitor do significantly better than those who don't in a variety of outcomes. But then there's a question, or is there a bias because people who use glucose monitors are a different population than those who don't? And is there a barrier to using it? And so our future proposal is to find people who have both diabetes type 2 using at least one shot of insulin a day, and we're still discussing study design and all, maybe a step wedge type study, putting them on CGMs and seeing the benefits and seeing how well they're able to use it and how it can be translated to primary care. And so we'll be using PCORnet in several ways, but I've kind of had to flip around how I'm using PCORnet. So the typical way, the way you did it for the initial studies, is you go to the front door, and then the front door asks different networks, do you want to join? And then if they do, then we talk together, and you give us a list of what you want from us and all. What I've done is found networks that might be interested, and then went the other way to the investigators that I know who have done CGM work and know how to teach it and all, as well as others who, and they don't have to be endocrinologists necessarily, but they have to be in this CGM dementia type field with it. Ask them, once I know their network wants to join, if they want to join, and then working with those groups in addition to the patients themselves, which and their caregivers, which PCORI absolutely requires, and as well as the Alzheimer's Association and others, to kind of build it from the ground up rather than the top down. And I think that's kind of what needs to happen. So is that helpful for you?
Yeah, absolutely. And I think it's a really good point that I agree that PCORnet, when PCORnet was being built, like when you and Russell and others were all kind of like really developing this at the very beginning, it was done because you guys already had existing relationships or other projects you all had worked on. And so I think the benefit of using PCORnet for like prospective data collection is there because it's still built on knowing the other people that are part of it, or knowing the institutions and how the data is collected. So it's really helpful to think about that as like, I get what you mean. We don't go to the front door first. We kind of build our team and then think about what data needs we might have from the EMR.
Yeah. But it is nice to have it all on one network and could go to one coordinating center to pull it out together. So you don't have to develop all those tools like we would if we just went to each other to do this study that we got a NIH grant or any other grants. So there's a question from Elizabeth about is it easier, faster to complete a research project with these tools or databases now, or still requires a lot of curation? It still requires curation. I don't know, Rosette, do you want to comment on that? Because you've
Yeah, I mean, I think
in your experience over time, has it gotten easier, or is it still about as difficult as it's been?
I think the thing is that it depends a lot on the local team that is managing how the data comes into the CDM. And Wade, maybe you can also comment on this. But I think it really depends on what's going on at the institution in terms of how the data comes in to know how much work you have to do to analyze what's there. I think it's gotten easier. Like when I think of how we did the initial computable phenotype projects at Vandy, and mainly because I think there are now people like you, Troy, and other clinicians who have really been in the space for quite a while. So even the conversations between clinician, data science, biostatistics, informatics, those have grown up and become more mature. So people kind of know what they're asking for and trying to do together a little bit better. But I think it's still pretty clunky. Like you really do need I think that's what I just say is that you really need a budget or not in terms of money, but time of team building and understanding like where this work happens and who you're working with. And I think, one thing I'll say is that like some of the big data sets like Cosmos, they're great because they're readily accessible. But the problem is like they're kind of like, meant for like, oh, go ahead and use them, not really on the curation side. And that may be nice in some ways, but also leaves you with some questions sometimes about, what you can ask.
Yeah, no, great points. And I think it is more, I think we have come a long way, both with some clinicians learning how to use it, but also with our data scientists and them learning how to use it, and then us learning how to talk to each other. I've been fortunate with having several data scientists who understood a lot with the clinical part. But I know sometimes it's learning each other's language too. And we've also, our statistical tools have come a long way over the past 10 to 15 years. I mean, I just remember early on, it was literally before propensity score matching. And you were always wondering, what's my control group and how am I going to get this control group? And all the true clinical researchers were saying, oh, well, this isn't controlled and, this group is terrible. And now we have really robust statistical tools to get a good propensity score matched cohort. And so, yeah, so it has gotten better, but it's really all about your team. And this is absolutely, if you couldn't see it from, I know I went through most of my stuff very quickly, but it's team-based science. This isn't your lab doing it. So I think we're up on the hour. I'm happy to go another few minutes, but if there aren't any other questions too.
I don't think we have any more questions. Someone did comment on the use of AI in this type of research database. Not sure if you saw that.
Oh, there it is. Yeah, I mean, there's still some barriers to it, but it is definitely being used in a lot of ways, especially here and through One Florida. It's just it's like Rosette said, it's the challenge of having the team to know what they're doing. So it's easy for us clinicians to have great ideas, but you have to have data scientists who know how to use AI and how to format these data into the right AI frameworks. So, do you have anything else to add or? No? Okay. Well, thank you. I really appreciate the invite. And
thank you, Dr. Donahoo.
we'll hopefully see many of you at ADA.